the Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. This episode is sponsored by our friends over at Hippo Education. Quick question. When was the last time you felt you were fully up to speed on the non-stop updates in pediatrics? Let me guess. Never. That's where Hippo Education's Pediatrics Reviews and Perspectives podcast comes in. Your monthly pediatric cheat code. Fresh, up-to-date insights from pediatric clinicians who live and breathe the same challenges you do. No fluff, no boring lectures, just practical knowledge you can apply on your next shift. The best part, you can listen and earn CME whenever it works for you on your commute between patients or during that rare quiet moment. So, if you're ready to make staying informed easier, check the link in the description or visit hippoeducation.com to try Hippo Education today. Good morning, George. It's another Tuesday and spring is upon us.
Yes, today we have another spectacular, wonderful guest. Her name is Dr. Rana Shami. Topic of discussion, from Beirut to Fairfax, leading a premier pediatric intensive care. Some stories behind the scenes. Take it away.
So today we are honored to host Dr. Rana Chami, a distinguished leader in the pediatric critical care and medical education. Dr. Rana serves as the medical director of the Pediatric Intensive Care Unit at Inova L.G. Murphy Children's Hospital in Fairfax, Virginia. She brings over 2 decades of experience in pediatric critical care medicine. Her academic journey began at the American University of Beirut, a place that is near to me, although I've never been there because of our friendship with Dr. Rani in Miami and my good friend, Dr. Karam, here in Sterling, Virginia, where she graduated with distinction and was introduced into the Alpha Omega Alpha Honor Medical Society. She completed her pediatric residency at the University of North Carolina Hospital and pursued a fellowship in pediatric critical care at Boston Children's Hospital. Beyond her clinical expertise, Dr. Rana is a passionate educator and innovator. She has held leadership roles in medical simulation and resident training, and she co-founded Parent Wise, an NGO dedicated to promoting healthy parenting practices. Welcome, Rana. It's a pleasure to see you.
Thank you, Herb and George, and thank you for having me on your podcast today.
Oh, it's our honor. We usually start by asking people why they became pediatricians, but with you, why the U.S.? You're so smart, you could have gone to France. I don't know, you could have gone to the Emirates. The world was your oyster.
That's a very good question. I think because I'm smart, I came to the US. It's the best place, honestly, to get medical education and to practice medicine and grow professionally. You can still ask me why pediatrics. I think a lot of people ask me this question. And honestly, when I rotated in pediatrics as a medical student, it wasn't love at first sight. I felt that peds was harder than any other rotation I passed through as a medical student. It broke my heart because I took care of patients who were sometimes dying of cancer. I got close to these kids. But then when I finished medical school, or towards the end, I realized that kids are really the helpless population I'd like to serve. A lot of the medicine pathologies or like adult pathologies to me felt self-inflicted, and children are really helpless, especially the younger ones. So that's why I decided to pursue pediatrics more as a challenge, but also it was to me a more noble cause. All medicine are noble causes, but to me, peds specifically stood out. And then why the US? I think, as you mentioned, you knew a couple of people from the American University of Beirut, and it has become really the default for people from AUB to come to the US to pursue their medical education. And I came here with my husband, we couples matched, and we decided to stay not only for further training, but also to work as physicians in the US. And then we decided to go back home to give back to our community. So we went back to our alma mater, the American University of Beirut, where we actually stayed for 10 years. I was the residency program director for PEDS. I established a simulation program. I gave it my heart and soul. And then when the country went through a financial meltdown, and then geographically it became unsafe for us to continue to raise our daughters there, we decided to come back to the US, it is a country that's only given us what's good for us and justice and the best education. And so we decided to come back, and here we are almost 4 years later, again, practicing medicine and providing to this country and to this community.
Wow, what a beautiful, inspirational story. Thank you so much for sharing that. And I have a special attachment to your PICU because of the founder, Dr. Steve Keller. What do you know and what do you want to share about Steve with our community?
Steve was really a leader in not only pediatric critical care, but also in pediatrics. He was the inaugural medical director of the PICU. He actually established the PICU at Fairfax once he was done with his fellowship at Children's National. So I've actually met Steve personally a couple of times when he visited the PICU last year, and everyone came to say hi to him. Some of the senior nurses remembered him. He established a PICU that serves the entire population of Northern Virginia and the surrounding areas. And believe it or not, but it's the only PICU in the area. And in 2017, after they moved to the new hospital, the PICU was awarded the American Association of Nurses Award because it was the way it was designed, it was really patient and family focused. And they were centered. It decreases anxiety because it's very bright. All the rooms are separate rooms, they're glass doors. There are nice designs and nice colors on the walls, and it's a place I'm so happy to come to every morning and serve these patients and families. But Steve Keller is definitely, again, a legacy, not only for establishing the only PICU in Northern Virginia. He was a very well-known educator. He authored many articles on pediatric critical care, especially when it comes to transport and poisoning ingestion syndromes. It was an honor to meet him. I wish I worked with him. The other person I worked with briefly just on some research involvement and task is Keith Dockery, who is also another partner
Phenomenal.
that Steve Keller worked with closely around the time when they worked in the PICU at Innova.
So this is before your time.
This is before my time, yes.
Yes, the first patient I sent to Steve was the first patient I consulted on at Prince William Hospital. Prince William Hospital is a low quality community hospital when I got there. Basically, if a kid sneezed, they call for the helicopter and sent them to Fairfax. No IV, nothing. They're totally different than the adults. The adults, they stabilize and then transfer to stable patient.
Yeah, that's a great story. And to me, you can imagine the pressure I was under to
Yes,
fill these large shoes
yes,
because, again, Steve founded this PICU, and then
yeah,
there was an interim medical director, Dr. Kathleen Donnelly, who is amazing.
yes.
But then basically I followed suit. So
Yeah.
again, it was a challenge.
But the kid had meningococcus meningitis, septicemia, and I don't know, but the work that Keith Dockery and Steve Keller did, he survived. I don't know how he had he had no blood pressure when I saw him in the ER, and was able to get access and transport him to Fairfax, and that evolved into a long friendship with Dr. Keller, Dockery, and Greg Futterman, who were the pillars of that PICU. There's also somebody that's passed away that we're going to talk to, his partner and mentor, Mike Altieri. So Mike Altieri was trained as a pediatric emergency room doctor, but he moonlighted in the PICU when the PICU was being started because they didn't have the budget for more. And those were that Fairfax was really just a community hospital before it became a referral center. And they had, because I think Craig was dual boarded in Peds ID, Peds intensive care and anesthesia. He used to be in the operating room with the open heart and walking back, and Fairfax was known for their cardiac program having better outcomes than many of the large centers in the Northeast. And they were bold enough to publish their outcomes every year. And I'm talking about, this is transparency 15 years ago. And whenever I know that I was a black cloud, I know that when the phone rang and says, Dr. Bravo from Prince William, everyone's like, no one's going to sleep tonight.
Mm.
But in none of my conversations with Steve, did he ever lose his cool. I'd be like, Steve, I don't know what to do. I've gone through the whole thing. The next thing is to put this kid into a coma in the emergency room because I can't stop him from seizing. Let's walk me through all the steps. I tell him, he's like, yeah, you've done everything. Yeah, you feel comfortable intubating him? Yeah, I feel comfortable to paralyze and intubate him. That's all you can do till we get there. We'll bring him back. Never did he get frazzled. He's an amazing human being. But you are too. I'm just saying that you have a tremendous legacy and a very well-respected institutional memory and a very fond memory of the pediatricians in Northern Virginia of all the work that you guys have done. So tell
Thank you.
me what the PICU looks like today, because it's a lot bigger than when I used to go say hi to my patients, my half dad, and say hi to Steve.
Yeah, and again, it's because of the right work that Steve and the very initial PICU physicians have done that we were able to grow so much now. We are actually now 10 intensivists, and two more are joining us from Boston Children's at the end of August. We also have three full-time nurse practitioners who can help us. So that's in terms of the physicians. The PICU itself has 16 beds. We can also expand further if we need to. We are now completely separate from the cardiac ICU. They used to be combined. So the PICU services that we provide is really just only pediatric intensive care. And when I say only, I'm undermining what we do. We actually provide everything there is out there for pediatric critically ill patients. So all the way to ECMO, dialysis. We take care of very sick oncology patients, traumatic brain injury, all kinds of trauma, big surgery, ENT is expanding, neurosurgery is expanding. So we do all kinds of post-operative care as well as like spine, things like that. And again, medically, we provide all kinds of respiratory support. So conventional mechanical ventilation, high frequency, all the way to ECMO. And then we also are part of a big multidisciplinary team. So it's not just physicians and nurses, but we have a big respiratory therapy group. We have pharmacists on the unit. We have a nutritionist on the unit. We have child life. We have palliative care. You should just see us, PT, OT, speech. You should just see us when we are rounding in the PICU. We're like a
A lot of
huge team of people moving around from one bed space to another. So I'm very proud to be really leading and managing this fantastic team of healthcare providers.
That
But
sounds
you,
impressive.
but you do a lot of open heart in kids, right? So,
We do. So again, the two units fully separated about a year and a half ago,
okay.
but we all did care for cardiac patients. We are all trained in pediatric cardiac ICU as part of our fellowship training, but currently the two units are separated. So the physicians who are covering the pediatric ICU side of things have an extra training in cardiac critical care, and they do all kinds, again, of open hearts in kids.
Oh, wow. So it's so the cardiac intensive care unit,
Mm.
pediatric cardiac intensive care unit has its own team now.
Correct,
Wow.
including nurses, nurse practitioners, physicians, and we have two full-time cardiothoracic surgeons as well.
Wow. Wow. That's amazing. And I haven't looked at the outcomes lately, but you guys had such great outcomes because of the attention to detail and families and the collaborative nature of that program at Fairfax between the cardiothoracic surgeons and the pediatricians and anesthesia. It's run
Correct.
The beauty of Inova, despite other problems, is that it is at heart a community hospital. And so it functions like the old hospitals used to function. A lot of collegial friendships and mentorships and helping people. That is very unique. And I think the people that are attracted to the hospital have that in their DNA. And that makes it such a great place to refer to.
Absolutely.
And you were mentioning to me that one of the biggest disease processes you see is children in DKA. About what percentage of the
So
work?
9 to 10% over the last 3 years have been children presenting with DKA. The big majority of these kids are new onset type 1 diabetes that was not diagnosed before their admission to the PICU. It was really shocking to me to see that, how much type 1 diabetes there's around us. And I think it's nationally and internationally, I think more and more kids and adults are actually being diagnosed with type 1 diabetes. And it breaks my heart when it's their first diagnosis, when they come into the ICU in DKA. The children are usually very sick, as they are, for the most part, neurologically intact, but some are not. They come in extremely tired, breathing as they have what we call dyscosmal breathing. So they're breathing very hard and very fast in order to blow off their CO2 to compensate for the metabolic acidosis. Their blood sugar is sky high. Parents are typically overwhelmed because not only their child is very sick and they need to be admitted to the ICU, but now they have to deal with this big diagnosis of a lifetime diagnosis of type 1 diabetes. So a lot of things are happening simultaneously when these kids come to the ICU.
Yeah. Remember back in the day, I think these kids used to go get admitted to the wards at the children's hospitals.
I never admitted anybody in DKA at the Children's Hospital because
Yeah.
most hospitals have a policy that you can't do IV insulin drips on the floor.
Further back in the day, before when you were an intern, they used to be on the wards, then they
No,
progressed to the ICU. At Montefiore, that's how it was.
yeah, no hospital ever
Not
practiced.
now, not now.
No, even back in '89, if you hung an insulin drip, they went to the PICU. They wouldn't allow you to put that on the floor.
Yeah.
In '89, it was even worse. In '89, when I started my residency in Michigan, they wouldn't allow me to do nebs every 2 hours on the floor. They have to go to
Mm.
and I'm like, are you kidding me? The rest of the world nebs the kids 3 times in an hour in a clinic, and they're not even in the hospital. And they're like, the pulmonologist, who's critical care doctor, pulled me aside and said, Herb, slow down. It takes time for new things to get adopted. You are absolutely right. There's no reason why somebody getting nibs every 2 hours needs to be in the PICU. But at this point in time, you have to accept it. That will change.
Yeah. That was more of a nursing because in order to give nebs every 2 hours, you had to have a whole lot of nursing care or more individualized care. Where in the PICU, they have, I don't know how many patients per nurse, and they have more patients per nurse in the ward. So that's why they couldn't do it.
Yeah, maybe so.
That's why, yeah.
It was a totally different world. I texted you yesterday because I couldn't stop laughing. Of course, I screen everybody at 2 and 4 years of age now. I screened a 4-year-old who has a strong family history of diabetes, and they're from Africa. And of course, one of the autoantibodies came back positive. So I'm dreading the conversation, like, how's this going to go? And it was the mom and the mom's sister, so the aunt of the child. I think I can say the aunt's name, Coco. Very cheerful, very nice young woman. And she kept thanking me. I'm like, this is so unusual. Usually they're angry at me because I'm delivering bad news. And then finally I stopped and I said, what do you do for a living? Because you seem to know a lot about diabetes. And you've thanked me 3 times for drawing the autoantibodies. And she said, "Oh, I used to be a PICU nurse at Fairfax. You won't believe the amount of DKA patients
Mhm.
almost dying that we saw during COVID. It was so overwhelming that I moved over to the NICU. And I said, "Oh, so you must know Dr. Rana." She said, "Oh, yes, I love her. She's so great. Oh, please, when you see her, tell her that Coco says hello." And I said, "Funny enough, I'm seeing her at podcast tomorrow. I'll make sure I mention you." She's, "Oh, wow." But she knew exactly what I was talking about.
Yeah, that's a great story, Herb. And the other thing is that sometimes I personally have to deal with in the PICU is not only telling the parents of this child that your child is in ICU, they're critically ill, we're going to wake them up every hour to check their neurological status, we're going to prick their finger every hour to check their blood glucose. And now they have this possible diagnosis of type 1 diabetes. And by the way, can you tell me a little bit more about your family history? And do you have other children? And you probably need to be screened. So you can imagine how overwhelming this is. But I'm glad to bring it up and make people aware that we can now screen for type 1 diabetes and possibly do something about it. And I'm glad to be able to mention it in the PICU because the parents will remember it and they will bring it up later on when they meet with the endocrinologist or with their pediatrician on follow-up.
Yeah, yeah. So what does that PICU look like? Remember, I started in 89.
Mhm.
It was a big innovation to have the Hewlett Packard monitors that looked like big TVs with cassettes that you put in there. The predecessor to that looked like a huge speaker at a concert. This thing was so huge. I don't know how they were able to hang it up there. And it did cardiac rhythm and respiratory.
Mhm.
That's all it could do. The pulse oximeter was a separate machine. All of these things have been changed now for flat screen TVs. And basically, if you were in respiratory distress, you got intubated and put on what I call a normal ventilator, not an oscillator, a normal ventilator. And then they were in ARDS. We cranked the PEEP until they blew a pneumothorax. That's what we did. You knew that's going to come, but either do that or the child dies because you can't oxygenate him. And I don't know, is it Rogers, the critical care textbook out of Hopkins? I don't know how many times I read the chapter in ARDS. And today, you don't have to use a laryngoscope to intubate people. You can use one of those other tubes that don't go into the larynx, or you can use a scope. And so you can actually see where you're going, being so traumatic. You were telling me that you guys are intubating less and are you using high flow oxygen, which for the life of me, I don't understand how that works.
So you bring up very good points. Yes, obviously, we've made a lot of progress in medicine, not a lot in ARDS, but in terms of monitoring and following these patients up in the ICU, obviously, there's a very fancy monitor by the bedside that everything connects to, basically. So even your end-tidal CO2 is on the monitor, even your intracranial pressure is on the monitor. Obviously, you see heart rate, invasive blood pressure, pulse ox, CVP if the patient has a central line. All of it is actually directly projected on the monitor, and we have telemetry screens outside of the patient room that we can also look at and follow, and they are in two different locations in the PICU. So no matter where you are in the PICU, which is shaped like a U, that's why, again, they got this smart design award. You can see the telemetry like everywhere you are in the PICU and look at these patients, identify the rhythms, alarms are on. You can print the patient's rhythm directly from the monitor. It's hard now to miss an event on a patient, which is great. And that's even before the introduction of AI, which again, I can only imagine that this is going to take medicine even further in terms of monitoring and identifying processes before they even happen. But when it comes to ARDS and high flow, we still put patients on high PEEP. Your medical practice is still validated. We see less and less pneumothoraces now because we have a specific sort of like set of protocol that we follow in terms of how to increase the PEEP on the ventilator, and we tend to do it gradually. But yes, we do crank up the PEEP. The high frequency oscillatory ventilation is another mode to try to inflate the lung and avoiding de-recruitment and avoiding lung injury this way. And then we again, just because we are an ECMO center, we actually have the platinum designation from the ELSO. We are a platinum center for ECMO. We tend to put these patients on ECMO sooner rather than later, and our outcomes are actually even better than the national benchmark when it comes to that. But yes, we are using more and more high flow, so much so that we probably some of the very similar cases that would have been intubated in the past, put on a ventilator, sedated, developed ventilator-associated pneumonia, all the consequences that come with that are now just being managed with either high flow or non-invasive positive pressure ventilation, like a BiPAP through a nasal, full face, or scuba mask type of like a device to achieve the non-invasive positive pressure ventilation and recruitment of the lungs. So the way high flow work, or another name for it is high humidity nasal cannula oxygen, it actually provides literally high flow of oxygen. So we can go to flows, in adults, you can go all the way to 60 liters, even more per minute. And in kids, we typically start 1 liter per minute, go up to 2 liters per minute, 2 liters per kilo. So 1 liter per kilo, then go to 2 liters per kilo per minute of flow. We don't usually escalate higher than that because the literature is showing that higher rates than 2 liters per kilo is probably not helpful. And that's when these kids need more aggressive support. But the high flow itself stents the airways open and provides some kind of PEEP. It is unknown exactly how much PEEP you're able to achieve in the lower airways, but at least some of it is to stent the upper airways open. And we can provide all the way up to 100% oxygen with that as well.
Oh, wow. And then are you guys using much bedside ultrasound?
We are using it more and more, and I anticipate that in few years, ultrasound will completely take over X-rays and diagnosing things like pneumonias, consolidations. We already use it, but it's not standardized in the pediatric ICU, but we use it for that. We use it a lot to identify pleural effusions. We use it, it's now the gold standard and standard of care actually in placing central lines. Like I remember when I started my fellowship, I used to place subclavians and IJ blindly, just following the anatomical landmarks. And I think I was privileged at the time because I had to know my anatomy very well. I had to know exactly where I was going, feeling every pop through the needle. And now the standard of care is to just do it via ultrasound, which again is safer, probably faster, and it's less complications, less pneumothoraces, less going into the carotid artery when you're trying to go into your IJ. We are now working on developing a protocol to maybe in neonates to start to look at endotracheal tube placement via ultrasound versus getting an X-ray to see where the end of the ET tube is. Again, all the abdominal processes, a quick echo at the bedside, all of this is done via ultrasound. If we're suspecting decreased flow in one of the vessels of the limbs, we're doing it again via Doppler and via ultrasound. Definitely, the medicine is changing when it comes to these diagnostic techniques.
And you're reading the bedside ultrasound.
Yes.
Yeah, it's not the radiologist. And again,
Mhm.
to your point, I can't, because radiology is one area where AI will have an impact quickly because it's just basically, it's digitized already.
Yes. There's
So,
even now an ultrasound probe
yeah,
that comes with AI capabilities that will immediately, once you put it on the heart, will give you ejection fraction,
that's what I mean.
everything
But
you're looking for, and it's on a probe.
Yeah.
but it's
So,
not ever available for us yet.
so you'll look for the pneumonia, and
Mhm.
the AI will have seen 5,000 pneumonias, and it will say, yeah, correlates with your diagnosis, or doesn't correlate with your diagnosis.
Yes.
That will be incredibly helpful. Wow, fascinating. I am so experienced. Really, I'm so old that the first central lines I used to put were femoral lines, and then those became, it was not no longer used because of complications. And then like you, I did all the subclavians, and my horror story is putting a Quentin catheter into a 16-year-old without sedation because she
Mm.
had Guillain-Barré syndrome. And the director of the PICU told me, you were not going to sedate her. I'm like, this is inhumane. He said, you sedate her, you'll never get her out of the vent. She'll end up on a tracheostomy. And she needs the electrophoresis, and it's the only way you're going to get it done. Don't feel sorry, you're saving her life. But
Yeah.
yeah, the feeling when you're putting those Quentins in and you're just ripping through tissue like there's no tomorrow. That's not something a pediatrician enjoys doing.
No. And again, sometimes you're stuck between a rock and a hard place, but fortunately now we have some options and closer monitoring in the ICU, providing sedation that might not necessarily lead to intubation. A lot of local, two people need to be present at the bedside, one for the sedation, one for the procedure. The ultrasound will make you poke less and poke more accurately or precisely. So again, we've come a long way since.
Yeah, with two people. I wrote the orders for the sedation. Then the PICU nurse helped me count up, and I cleaned the site, and there I went. Oh, it was such a different world. It was cruel. Now, I think I get the impression you're a big proponent of using data to manage and improve. How are you using data to manage and improve what you do every day?
So again, the PICU at Innova is part of the virtual PICU platform. So we collect a lot of data on every patient all the time, and they go into a virtual PICU database that we have access to and that we use to basically monitor and track our performance. We're also part of other national databases, so this way we can compare our performance on many issues with the national benchmark to see where we are when we are compared to hospitals our size, basically, and our setting. So this, in addition to, again, as I mentioned, I think Innova it will be contracting with its own AI company to track basically even and monitor even more closely the information on patient-to-patient basis. We are lucky to have Epic as our EHR because Epic itself has a lot of data and information on every patient. And we have the privilege in participating in multiple international multi-center randomized controlled trial. So we also keep our data in check this way, and we keep
Oh,
monitoring our patients this way.
well, and do you use any data visualization tools like Tableau or?
Yes, we use Tableau.
Okay.
And I, as the medical director, have access to all the Tableau information also in our hospital. But this is what we use, yes.
Wow. Well, isn't Tableau phenomenal?
It is phenomenal, like the amount of information that we can get. We also get a lot of feedback from our patients and their families, and all of it goes on Tableau as well. So
Oh,
we
Who manages
try.
that Tableau?
they have a team. This Innova is a huge
It
organization.
has to be a lot of because
There.
Tableau. Herb and I became experts by accident on this Tableau stuff. And it's really hard. It started off as, some kid can figure it out. We certainly can figure it out. Took us a while, but we got it. Like snowboarding, uphill,
Yeah,
very difficult.
yeah.
Very difficult as a
Again, we are
physician.
privileged to have experts in Tableau at Innova who help us with data management and
Yeah.
understanding what it's collecting, but it does collect a lot of stuff.
But there has to be some physician involvement in this because
Yes.
these computer people, they just see boxes and cells and columns and rows, and they don't understand the medicine. A physician that understand some computers or Tableau-like stuff say, let's do this, let's find this, let's check this out. Because usually, as with all EHRs and all technology, these engineers will just throw everything at you because you want everything, doc.
Yes, obviously, we have physicians' involvement in this to clarify and interpret the data. They are physicians' IT experts, if you want. Obviously, they're younger than me, but
You could
again,
be my grandchild.
they love this sort of stuff. So we use multiple, I think, platforms to keep up with our data. We also use another one called Vizient, and that's to keep track of individual physicians' performance when it comes to, let's say, readmission rates or bounce backs or mortality or central line complications or procedural complications. So that's also another platform. A lot of tech. Let's put it this way.
Yeah.
Oh, boy.
But what kind of leader are you? Because you're a phenomenal leader, but what is your leadership style?
Thank you, Herb. I think I would call myself more of a democratic type of leader. I let people participate in most decisions when it comes to the PICU itself, the PICU operations, the education, the research, the simulation in the PICU here. So I have people pitch in. I'm not autocratic in the way I lead things. Having mentioned that, I know that the democratic leadership or the participative leadership can come with some risk if you cannot really make an executive decision at the end. So I think this is the style I mostly practice is I hear everyone, I take everyone's opinion into consideration, but I'm very careful at drawing an executive decision at the end that people would support. And I also am very inclusive in the way I lead the ICU. I collaborate very closely with our nursing colleagues. We don't function in silos. I try to be multidisciplinary in my approach as well when it comes to the PICU in general. And I not only lead a team of physicians, but I lead a team of healthcare providers, which I'm very proud of. So I think this is how I would describe my leadership.
So you're not like my dad. My dad told me when I was a young kid, he said, I'm a benevolent dictator. Express your thoughts so I can hear them. So I did. He said, yeah, that's not going to happen. We're done.
Yeah, I think this is how I grew up as well.
The benevolent dictator leadership model.
Sometimes leading physicians is not the easiest thing in the world. I remember back in the day when the EHRs were coming out and they were customizing and doing things. And I put out a question to the IT people. I don't understand why we can't agree on how we can describe what an ear infection looks like. It's pretty simple. He says, Doc, you would not believe that if I asked 3 physicians how to describe an ear infection, I'll get 5 different versions. And they all want it and they all think they're correct. And they're probably all relatively correct.
Yeah, I think you're totally right. When I was interviewing for this position, actually, the vice president asked me a question that I will never forget. She told me, you are the residency program director, because that's what I was at the time when I interviewed here. I was the residency program director at the American University of Beirut. So you are comfortable in leading people who are younger than you. You are now going to be leading a team of physicians who are mostly older than you. How are you going to do that? And it resonated with me because I had to change my leadership style a little bit to be, again, more inclusive and more democratic. And it's been working well for me. Since then, I'm now the upcoming president for the International Pediatric Simulation Society. And I'm the vice president for the International Lebanese Medical Association that's based in the US. So I think I've learned a lot from my current job, and I'm happy to be able to replicate some of my leadership skills into other fields as well.
So tell me more about simulation. What do you mean by simulation?
So simulation, to put it very plainly, is when you train and practice your medical skills on a mannequin, for example, versus practicing on real patients. It has become one of the pillars of medical education now. It's not novel anymore. It's being practiced almost everywhere, whether it's low fidelity simulations in countries with low resources or high fidelity simulations with big, advanced, highly technical mannequins and bells and whistles in countries with high resources. And basically, it was mostly shown to be helpful when you are educating people on multidisciplinary approach to medicine, where, for example, the way I do it in the PICU, and we do simulations in the PICU every month, we have a mannequin that is a child, let's say a 6-year-old, let's say with status epilepticus. And we start with the nurse at the bedside. We try to suspend disbelief that this is a mannequin, but it's connected to a monitor. It acts almost like a human being. It has a pulse ox, it has sounds, it cries, it seizes, it has pupils that dilate and restrict. And then the bedside nurse would come in. She would see that the patient is seizing, is hypoxic, tachycardic. She would try to give the first dose of Ativan. The mannequin usually has an IV, and it's physiologically built that it would respond to the medication that you are giving. So the nurse would give an Ativan that is labeled for simulation. And then let's say the seizure doesn't stop, she has to call the physician. The physician comes in, they go through the protocol of status epilepticus, they call the attending, they decide to intubate, they get more nurses, they get more resources. There's a simulated actor who is acting like the parents, who is crying, who needs to be managed and appeased. All of these things, we simulate them in the ICU, and then we just talk about them, talk about went well, what could have gone better, and lessons learned, and what are the lessons that we can take away for next time. This is just an example,
Wow.
but I'm making it sound very plain now.
Wow. It's like the pilots, right? No, all the
Yes.
pilots for the commercial airline pilots have to sit in a simulator, the kind of jet that they fly, and they put them through fire drills of your right engine just went out. What are you going to do to prepare them for events like that can happen in the air? Wow, that's fascinating.
Yeah, this is practically, we do this on weekly basis in the ICU. We have now a simulation curriculum, especially as we start our fellowship, we will have a simulation curriculum that will complement the didactic lectures and the didactic learning that the fellows will be doing.
Wow. So tell me about that your fellowship.
Yes, so as you mentioned, Herb, at the beginning of this podcast, I'm an avid educator and I have not been able to let go of this hat.
Mhm.
So I decided to pursue it and bring advanced education to our PICU Innova Children's. So after a lot of hard work, I got our PICU fellowship approved, and we are starting with our first PICU fellow this July. So we are very proud, and we're
Congratulations.
hoping to recruit more and more fellows with time as well.
So how many slots are you approved for?
I'm starting off with one per year. I'm
Okay.
hoping to go to two per year very soon, and then hopefully to three per year after that. There's no reason why we cannot have a big fellowship program. We have a very busy PICU that does almost everything, including transport, trauma, ECMO, all of that. So there's no reason for us not to have a PICU fellowship, and I'm very glad to have gotten it approved.
And will your fellows work in the cardiac ICU too, or
Yes, it's a fellowship requirement actually to do 5 or 6 months in the pediatric cardiac ICU, so it is built into their block schedule as well.
okay? And they're 2 years clinical and 1 year research, like all the pizza fellowships.
Overall, it's actually not that delineated, so they start their research within, like in the first year even. So then it's not basically cut into 2 years of clinical and a year of research. It rather functions more in blocks. So they will get, let's say, PICU, PCICU research, and then a month of transport, then a month in the adult trauma ICU, and then they do a month of anesthesia, then a month of research again. And then this is how it's built. So it's like back and forth in order to provide them with some break. But also, as the fellowship progresses, they will get more and more back-to-back research months so that they can actually achieve meaningful research projects by the
Oh,
end.
wow. Wow. Congratulations. That's an
Thank you.
awesome achievement.
Do
I
you want
mean,
to join our fellowship?
yeah, I do.
You're a scud monkey.
I don't know. I don't know if you guys could stand me for more than a week, and if
Oh,
I could survive, if I could survive 2 overnights before I have a stroke. Just staying up 24 hours a day is not easy.
Yeah, not easy, but I think now the way the ACGME is structuring work hours is they will rarely have to do 24 hours straight. So even when they're on at night, they come in for their night shift and then leave the next day. I think there are still some rotations where they have to do 24s, like the adult trauma ICU, but most rotations don't have 24 hours anymore now.
Yeah,
It's more
it's
humane than the way
more,
we
much
had
more
it.
humane, but you learn so much on those night shifts when these were the cowboy days, right?
Oh, yes.
You were a second year resident in the PICU, and there was no attending in-house. There was no fellows in
Yes.
town in-house. You were it.
Yes.
Yeah, I can call Dr. Rana at home, but it takes her 30 minutes to come in. I better keep that kid alive for the next 30 minutes.
Yeah. I
Um,
think we actually used to think that we missed out on the nights we were not on.
yes, yes. And then you develop or at least I developed relationships with the nurses. And when I was in service as a second and third year peds resident, they're really critically, there's always these children that they're train wrecks. If
Right.
you put the dopamine too close to the bedside, they decompensate. But
Hmm.
if you move it too far from the bedside, they decompensate. But you're not even giving them the drug yet. And the PICU nurses, for those patients, they would just say, "We're calling you at home, but I'm not on call. There's a team here." Yeah, the patient, you know how fickle they are. You leave it to one of your colleagues that's just doing call and not in the PICU. They'll give the wrong order, and then we'll have a disaster you have to deal in the morning with. And they would.
Yeah, and then obviously you can't sleep when you get such a call. So you
No,
better
no.
just come and be in the
Yeah,
hospital.
but boy, did I learn. Boy, did
Yeah.
I learn a lot. And to your point, I learned as much from the PICU nurses as I did from some of the PICU attendings.
Oh, totally.
You
Absolutely. I
know,
mean, these
um,
experienced nurses are wonderful.
oh,
curious, are you guys dabbling in like remote tele ICU work, like in areas that have a step down PICU, that have a ward, but they don't have enough funding to have an attending in order to keep
That's
them without transferring?
that's a very good question. I know they definitely do it in the adult ICU. Like
Yes, I have a very
it's definitely established in the adult ICU. They do that.
yes.
What we do is we provide telehealth for transport. So let's say we have a patient at a outside community hospital that we send our transport team for, or even before we send our transport team for, and they call us and they're very concerned. We have the option to tell them, okay, turn this iPad on or this camera on, that we have a healthcare system that we work with. And so they can turn their cameras on and we will be able to see the patient. Because sometimes when you actually see the patient, you get a different picture from what is being described, especially if they are patient with neurological dysfunction or patients in respiratory distress. So we have the option to offer that in some community hospitals. And even if they don't have that iPad or these capabilities, we can offer like video conferencing with them so that we can see what they're talking about. But it's not, we don't routinely telehealth with other ICUs because of all the complexities that come with that as well.
I have a very good friend of mine. We had him on the podcast, Dr. Jeffrey Sadowski. His whole role is remote ICU. That's his whole organization. And what their model is, they work within Epic and they have a number of hospital systems that have ICU, but they don't have enough volume to support a physician. So rather than shipping them out for 3 hours, they keep them there and they go in and they round on the patients and they write progress notes as you would in person. So if you have 3 or 4 little hospitals somewhere in the middle of the United States that don't have access to care, they manage that. And it was pretty amazing stuff. Yeah.
Yeah, that sounds great. We are fortunate to have transport services for a pretty big catchment area. So we bring a lot of these kids over and just take
Right.
care of them here.
Yeah. I think adult medicine, pediatric medicine are very different.
Yes.
Yes.
There's almost I would say there's almost an interventional cardiologist at every hospital in the United States now.
Yeah.
It's not just like part of it, but there's not a pediatric endocrinologist in every community hospital in the United States. And there's not a pediatric cardiologist at every hospital in the United States. There are even less pediatric hematologists or oncologists or nephrologists in community hospitals. And even the surgeons don't like to operate on the kids anymore. They send the kids to the pediatric surgeon. So without those resources, it's really hard to keep a really sick kid
Yeah.
in a ward in a community hospital because you just don't have any of the subspecialty support. Not to mention the nursing skills,
That is true.
or the child life, or the psychologist, or the nutritionist, the psychologist that can talk to the parents in a way that makes the pain of this trauma more bearable and gets it back focused and doing what they need for their child. And those all are very important components of the critical care that people like you give children.
Yes.
But it is a good model for emergencies. We met through some of the work that we do together in educating our fellow pediatricians on screening early to prevent DK. And you seem to be just as passionate about this as I am. Was it your experience here in the PICU that has driven you to that passion, or did you also see it in Beirut?
Thank you for this question. I've always been an advocate of pediatrics in general. When I was in Beirut, I founded an NGO to advocate for like healthy parenting called Parentwise. I've always been an outspoken person when it comes to doing the right things, not only by your child, but by your community and by yourself. Like, I'm also a big advocate of taking care of oneself physically and mentally. But when I came to the US, to the PICU here, just because of the sheer number of admissions that we get, I was amazed by the large percentage of DKA patients. When I worked at Boston Children's, as Boston Children's is a referral center, so we did not necessarily see patients who were coming in with DKA. I saw some of them at Boston Medical Center because we used to occasionally cover the PICU there. But the patient population of Boston Children's was very different. So I didn't see many DKA in Boston Children's. And when I saw them, they used to be extremely sick and they would be like sent over to this referral center. In Beirut, for some reason, I did not see a lot of DKAs. Beirut is a much smaller place. The PICU in Lebanon is much smaller. We saw some, but it was definitely not 9 or 10% of our admissions. But then when I came to this large area where, again, the PICU serves a whole region, it struck me, the percentage of DKA patients struck me. And that's when I decided to do something about. And I started basically advocating for DKA, for awareness on type 1 diabetes. There's nothing that people can do to prevent type 1 diabetes from happening, but there are things that possibly physician and parents can do to maybe delay its onset, prevent DKA, which to me is a very dramatic presentation of a first diagnosis of any illness.
Yes, absolutely. Absolutely. It's a scary, horrible disease. I don't know. You're so talented. Maybe after many years of dealing with critically ill children, few things scared you. But DKA scares me. And the trauma that the parents go through is incredibly painful. And because of my personality, I like to fix things. I don't have a fix for their child's disease.
Yes, exactly. And I have to tell you, Herb, DKA still scares us. Again, the majority of kids do very well and they stay in the PICU for 24 hours. But when they do get the cerebral edema, when they do get the neurological dysfunction that comes with DKA, we are scared to death because every intervention has the potential of making them worse. If you decided to intubate them because they're having the cerebral edema, that's going to worsen their increased intracranial pressure.
Yeah.
If you're going to take them down to CT, like the whole trip and the whole thing of transporting them is going to make them potentially worse. Like, again, it definitely still scares us even so many years later. And even with the majority of kids being okay, when they're not okay, we are actually scared to death.
Yeah, it's a disease like meningitis used to be.
Yes.
One step away from death. And then same with head traumas with the bolts, what you're
Yeah.
describing. Right?
Yeah.
And you can't make noise in the room. You got to do this, you got to do that because any little thing that intracranial pressure will spike and the mannitol and hyperventilation don't work. You have
Right.
a patient that herniates and you're done. Game over.
Yeah.
Yeah, it really is living on the edge and incredibly scary. Thank you for that work that you do. I admire so much of what you've done, but I think if I could put you out of business by taking that 10% of patients away from the PICU, I would be incredibly happy. We find something
Trust me,
to
I
do.
would be happy to.
We
I would
find
be
something
happy
else to do.
There's always
Yeah.
something else to do.
Yeah.
Tell me about the NGO Parent-Wise. What is that and where can people find it? Where can they donate?
So unfortunately, just like I left Lebanon 4 years ago, many of the co-founding original members left as well. So it actually, parent-wise, is very dear to my heart because I started it with a teacher. I
Hmm.
started it with an elementary school teacher whom used to she used to bring her children to me, but that's not how it all started. I actually met her through a friend, and we are both advocates of children and raising them well. So we started brainstorming, and then we reached out to OBGYN in Lebanon who did maternal fetal medicine because I really think pediatrics starts in the womb or even before that. We added a psychologist, a special needs educational person as well, and a pediatric nutritionist to our team. And we started brainstorming. We started going around the country giving free workshops about parenting and raising awareness on healthy practices, whether it's in pregnancy, whether it's the first 100 days of life, how much to read to children, how to manage screen time, vaccinations, healthy nutrition, whole foods, identifying autism early on or any learning disabilities that children might have early on. We did fantastic work for, I think, around 2 years. And then when the crisis happened in Lebanon and the region, actually every single one of the founding members left Lebanon, and we are now all over the place. Marwa, who is the co-founding member, who's a teacher, reached out to me. She's in Qatar now. She reached out to me and she's, what do you feel about trying to resuscitate Parent-Wise and try to revive it? So there are some talks in the background about possibly going back to it again because of all the amazing work that we were doing in Lebanon. But it's now like on the back burner, unfortunately, because I have so much on my plate.
If you ever retake that and there's something I can do to help,
Thank you. I'll
I
keep
would
that in mind.
I would love to be part of that.
Thank you.
George, do you have any?
I think this was a wonderful episode, very enlightening. And let me tell you, the ICU of today is different than the ICU of yesterday.
It was not just yesterday, decades ago.
Yes.
I remember we had this famous ICU attending that used to say, if you never had a complication from a procedure, that means you didn't do enough procedures.
Yes,
That's true.
yes, exactly. And that's what I tell my team sometimes because we get frustrated with unplanned extubations. And sometimes I tell my team, if we don't have any, it means we're over sedating these kids. It's really an art. It's a very fine balance. And yes, we are physicians, we are scientists, but we are also artists, I think, in what we do.
Oh,
Yeah. And I think, unfortunately, sometimes all we have to give a parent is compassion. There's no cure.
Yeah.
The outcome is not going to change.
Yes. And again, this is one of our missions, right? Is to support families in the ICU. Of course, we want to save a life and we want to provide the best outcome possible. But as you mentioned, Herb, sometimes we can't. Sometimes these kids come to us too late, or they come to us with such a devastating injury that there's nothing we can do to reverse it, or to give them the child they used to know. And supporting the family through this becomes even more essential when the outcome is not guaranteed.
Thank you very much for your time. I'm sure I'll see you soon.
Thank you so much.
Yeah, I'll
You
see
guys.
you sneak
Bye.
into what some of your rounds.
Yes, you're always welcome, Herb.
Thank you. Thank you.
Have a good day.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.